Dear friends, in this video, I am going to talk about some of the recent updates on ARDS in line with the new global definition of ARDS, which came in 2024. We know that for quite some time we have used the 2016 Berlin definition of ARDS till last year when the definition was amended, and it was amended with certain reasons. The reasons were that there was a need to find a new definition which can identify patients with the currently accepted conceptual framework for ARDS, facilitate rapid ARDS diagnosis for clinical care and research, which can be applicable in resource-limited settings, which can be useful for testing specific therapies, and which can be practical for communication to the patients and the caregivers. So these were the basic reasons or objectives while this new global definition was searched for, looked, and framed. Now, if we see the diagnostic criteria for the new global definition of ARDS, we find that there are certain criteria that apply for all ARDS categories, and there are certain criteria that apply to specific ARDS categories. In those criteria that apply to all ARDS categories are the risk factors and origin of edema, the timing, and chest imaging. If we go by our previous Berlin definition, we find that the risk factors and origin of edema remains more or less the same, with a stress that the pulmonary edema is not exclusively or primarily attributable to cardiogenic pulmonary edema or fluid overload, and hypoxemia or gas exchange abnormalities are not primarily attributable to atelectasis. So this remains more or less the same. With regard to the timing, acute onset or worsening of hypoxic respiratory failure within 1 week of the estimated onset of the predisposing risk factor. So that also remains unchanged with regard to the definition. With the chest imaging, bilateral opacities on chest radiography or CT remains the same, or bilateral B lines and or consolidations on ultrasound not fully explained by effusions, atelectasis, or nodules on muscles. So this is something which is new and which has been added to the new global definition of ARDS. Now let's look into the criteria that apply to specific ARDS categories. We know that the criteria is for oxygenation. Now in this case, there are 3 separate categories which has been added. 1, the non-intubated ARDS, 2, the intubated ARDS, and 3rd, the modified definition for resource-limited settings. In the non-intubated ARDS, the PF ratio of less than 300 millimeter mercury remains the same. But in addition, there is a SF ratio, that is the SpO2 by FiO2 of ratio less than 315 if the saturation or SpO2 is less than 97%, that is extra. On HFNO with a flow rate of more than 30 liters per minute, that is extra. Or NIV or CPAP with at least 5 centimeter of water end expiratory pressure, that remains the same as it was for the Berlin definition. In the intubated ARDS category, we see that the division between mild, moderate, and severe remains the same for the PF ratio as it used to be. That is less than 100 for the severe, 100 to 200 for moderate, and 200 to 300 PF ratio for mild. But in addition to that, the PF ratio has also been added, and this PF ratio should be less than 148 for severe, between 148 and 235 for moderate, and between 235 to 315 for the mild variant. So this is an addition in the new global definition of ARDS. If we look into the modified definition for resource-limited settings, we find that apart from this SF ratio, neither positive end expiratory pressure nor a minimum flow rate of oxygen is required for diagnosis in resource-limited settings. Or in other words, those patients in resource-limited settings who would not have qualified for a definition of ARDS now gets included in ARDS with the simple reason that despite not being on positive end expiratory pressure or a minimum flow rate, if they fit into the criteria of SF ratio of less than 315 with a SpO2 of less than 97%, they still qualify under the 3rd heading or the 3rd specific ARDS category. So to sum up, you see the key differences between this new global definition of ARDS and the Berlin definition, we find that the acute onset within 1 week of known insult or known remains the same. But in this group, the inclusion of patients with HFNO will capture some patients who were missed earlier, who had more indolent courses, and the timing criteria could not fit because they had exceeded. So that escaped. So they have included because the onset may be more indolent for some insults like the COVID-19. The bilateral opacities on chest X-ray or CT, which not explainable fully by effusions, lobar lung collapse or nodules. Now that part has been further amended by the inclusion of ultrasound. We know that ultrasound is a bedside procedure almost always routinely practiced in ARDS patients. So multiple B lines and or consolidations have been taken as the criteria so that this group of patients can get identified even before their chest X-ray or CT chest is available. The categories of SpO2 by FiO2 ratio or the SF ratio, if the SpO2 is less than 97%, they get admitted under the category of ARDS. And also we see that the requirement for invasive or non-invasive mechanical ventilation such that PEEP more than 5 centimeter required for all categories of oxygen severity except mild. For in the mild cases, we get a CPAP of more than 5 centimeter. This has been obviated in resource limited settings because modified definition of ARDS for resource limited settings does not require this PEEP or HFNO. So the new category of non-intubated ARDS criteria with an HFNO of more than 30 liters per minute also falls under the ARDS definition and criteria, which otherwise would not have fallen. So if you see the three types of patients, a 68-year-old male with abdominal sepsis, septic shock, and acute hypoxemic respiratory failure, mechanically ventilated, FiO2 of 0.2, PaO2 of 75, so the PF ratio of 150. This falls under the category of intubated ARDS, very similar to the old Berlin definition of moderate severity. 54-year-old female with history of breast cancer, COVID pneumonia, worsening shortness of breath for the past 6 days on HFNO 40 liters per minute, FiO2 of 0.8, SpO2 of 91%, falls under the SF ratio of 114. So again, it is a non-intubated ARDS under the new category in the global definition. 39-year-old female with abdominal sepsis with gram-negative bacteremia in a small under-resourced hospital without facilities for blood gases, radiography or mechanical ventilation, only being administered supplemental oxygen with face mask at 15 liters per minute, FiO 2.6, SpO2 85%, SF ratio is 142. This also comes under the definition of ARDS in the category of ARDS in resource limited settings. So both non-intubated ARDS in resource limited settings are the new categories in global definition consistent with the Kigali modification. It is very important to know today how quickly we can differentiate between ARDS and acute heart failure because they sometimes mimic. And although there are a lot of distinguishing features, both clinically and in laboratory wise, but sometimes there are overlapping features too. So that makes the diagnosis or the separation difficult. Like in terms of clinical history and presentation, there are a lot of similarities. In laboratory findings, we can see that the elevation of natriuretic peptides is only mild in ARDS, but it is marked in cases of acute heart failure, along with elevation in troponin. Where on the other hand, in ARDS, there is elevation of C-reactive protein, ferritin, with relative lymphopenia, D-dimer fibrinogen, etc. The other important thing is that the chest radiograph. In ARDS, often there can be normal cardiac shape with minimal or patchy opacities, but in patients with acute heart failure, there can be increased cardiac shape with interstitial edema and pulmonary venous congestion. The echocardiography may show no evidence of cardiac dilatation, left ventricular hypertrophy. There can be normal or mild increase in pulmonary pressures only in ARDS, whereas in acute heart failure, there will be right heart failure with pulmonary pressure increase, and there will be pericardial effusion with preserved ejection fraction heart failure or worsening of congestive heart failure. There can be these features as well. The lung ultrasound scan, the B lines are usually localized in 1 or 2 contiguous districts in cases of ARDS, and they're prevalent primarily in the subpleural distribution, reduced length, hyperechogenic look, whereas in lung ultrasound scan in acute heart failure, the B lines are symmetrically distributed in all chest sites. The prevalent localization into the inferior lobes and are bilateral. Likewise, there are little bit of differences in chest CT and MR as well. So this differentiation between ARDS and AHF has been something new, which has been explored, tried, and new evidences have been found out. With regard to the pathology, we find that some new insights have given that there are pathological changes, both pulmonary and extrapulmonary. Extrapulmonary is the systemic. The pulmonary pathological changes encompasses the endothelial barrier dysfunction, cell-free hemoglobin, decreased resolution of pulmonary edema, cell death, cellular senescence, and cellular dysfunction primarily, whereas the systemic pathological changes, depending on whether they are innate immunity driven or adaptive immunity driven. So changes in macrophages, monocytes, dendritic cells, neutrophils, and eosinophils in cases of innate immunity driven changes, whereas for T cell complement activation, etc., for adaptive immunity driven changes, ultimately leading on to immune thrombosis. Now we know that the risk of thrombosis is very high in this group of patients. The other important research which has taken place in ARDS and a lot of new facts have come out is in terms of the phenotypes. We know that the Berlin definition had created 3 phenotypes depending on the severity on the basis of the PF ratio. Now, this has been found to be useful, particularly in prone positioning, where a cutoff of less than 150 has been found to be useful clinically, and a PF ratio of less than 150 has also been found to be useful for the administration of cisatracurium, that is the neuromuscular blocking agents. Now, besides this, there are also some other phenotypes like ARDS by precipitating risk factor, sepsis, trauma, pneumonia, etc. This have also been explored, but as of today, the potential therapies on the basis of these phenotypes have not been able to be identified. But there are differences which has been observed in terms of ARDS risk, severity, and mortality. There has been differences in terms of direct versus indirect lung injury. Direct lung injury like pneumonia, pulmonary contusion, indirect like non-pulmonary sepsis, transfusion, etc. And here also the potential therapies could be placed on the basis of these differences in phenotypes, epithelial versus endothelial targeted therapies, and also the indirect form of injury is more likely to respond to PEEP. Regarding the timing of onset phenotypes, that is those developing ARDS before 48 hours versus those developing after 48 hours, although differences have been noted in the clinical characteristics, but potential therapies on the basis of this phenotype is yet to be identified. In terms of radiographic phenotypes, non-focal or diffuse versus focal or lobar phenotypes have been identified. There has been differences in mortality, lung compliance, etc. And among the potential therapies, the diffuse one is found to be more likely to respond to PEEP. For genetic defined endotypes of ARDS variant by genetic variability has also been tried, and there has been differences with regard to the risk, outcome, and response to treatment. And therapies targeting biologic implicated by genetic variants is the latest thing in the ARDS research. Similarly, for biomarker-defined endotypes, also therapies targeting biology implicated by the biomarker has been identified and worked upon. The most common phenotype has, however, been the hyperinflammatory versus hypoinflammatory or the uninflamed phenotype. And here also, a lot of differences have been observed. The hyperinflammatory type of phenotype of ARDS has been characterized by elevated plasma inflammatory biomarkers and has been found to have a higher mortality. And also, the phenotypes respond differently to PEEP and fluid strategy. Survival benefit has also been observed with response to simvastatin in hyperinflammatory phenotype. Now, if you look into the trials that have been conducted and which have distinguished these two phenotypes, hypoinflammatory versus hyperinflammatory, the ARMA trial, the alveoli, the FACT, MARS, and the more recently the HARP2 and the SAILS trial, there has always been a tendency that the mortality has always been higher with respect to the hyperinflammatory phenotypes as compared to the hypoinflammatory phenotype. Although the predominant of the study population demographics have been more of the hypoinflammatory variety. Only thing is that in simvastatin therapy, significant differences have been noticed with benefits to the hyperinflammatory phenotype, although the similar benefit has not been noticed with rosuvastatin, although this is also a statin. If we look into the main therapies today, the therapies can be classified under 4 broad umbrellas: the supportive therapy, the cell therapy, the targeted therapy, and the personalized therapy. The supportive therapy is the one which is the most commonly practiced, and the evidence is maximum. This includes the ventilatory strategies, the neuromuscular blockade, the steroids, and the extracorporeal support. Within the ventilatory strategy, of course, we have HFNO, we have NIV, and the invasive mechanical ventilation, besides, of course, prone positioning. In cell therapy, we have come up with cell component therapy, stem cell-based therapy, and non-stem cell-based therapy. Within personalized therapy, there has been personalized mechanical ventilation, personalized medicine, and organ function dependent personalized strategy, which has been relied upon on the basis of the phenotypes. And targeted therapy has also been relied upon the phenotypes, including targeted immunomodulatory therapy, other targeted therapies, etc. So although a lot of research is still in the early or in the middle stage, there has been a lot of important observations. And if you look into the recommendations by the ESICM and the American Thoracic Society on the clinical practice guidelines, we find that HFNO has a strong recommendation in acute hypoxic respiratory failure for both COVID and non-COVID, although the evidence, the quality of evidence is moderate with non-COVID and low to moderate with COVID. The CPAP or NIV has no recommendation. The higher PEEP to FiO2 strategy has no recommendation. The low tidal volume and ventilation has strong recommendation for both ARDS and COVID ARDS with high quality and moderate quality of evidence respectively. There has been no recommendation for PEEP titration guided principally by respiratory mechanics, but there has been strong recommendation for prolonged high pressure recruitment maneuvers. There has been strong recommendation for prone positioning in both ARDS and COVID ARDS with high and moderate quality of evidence, and the timing of prone position too, although the recommendation has been weak for brief high pressure recruitment maneuvers. If we look into the awake prone positioning, there has been no recommendation whatsoever. With neuromuscular blocking agents, the recommendation has been strong for ARDS, but no recommendations for COVID ARDS, probably because of lack of adequate number of studies. With VV ECMO, there has been strong recommendations for both ARDS and COVID ARDS, despite low quality of evidence for COVID ARDS. There is conditional recommendation also for ARDS with PF ratio of less than 80 and pH of less than 7.25 and PCO2 of 60 and above. The ECOR has found strong recommendation for both ARDS and COVID ARDS, although the evidence for all the recommendation for corticosteroids is conditional and for patients with PF ratio of less than 300. Now, the final take-home message after all that, ARDS is characterized by acute hypoxic respiratory failure with diffuse pulmonary inflammation and bilateral edema that we all know, and that is because of excessive alveolar capillary permeability in patients with non-cardiogenic pulmonary diseases. It is highly heterogeneous as it is evident from the enormous number of phenotypes that has been so far unearthed, not to speak of the further endotypes and the genotypes. It can include diverse pathological causes, direct injury, non-direct injury, indirect injury, lung causes, extrapulmonary causes, and so on, variable clinical presentations and treatment responses. And as of now, personalized medicine approaches for patients with different phenotypes might be a goal for future treatment. Thank you.